Right. So I'll get started. Again, thanks everyone for coming out. That was a really tough talk to follow. Susan, that was amazing. It's the first time I've heard her story and kind of seen how she talks, and I was really struggling to keep the tears back. So thank you so much. That was amazing, and I'm sure we're going to have the same kind of situation when we hear everyone else talk. So, and Dr. Gupta, that was amazing talk again. Thank you very much. So I'm going to talk a little bit more focused, a little bit about liver-directed therapy and some of the options and ways that we kind of approach that here at St. Vincent. First, before we get there, these are the guys that keep me going at home. That's my 4-year-old daughter, that's Elian, and that's my 2-year-old son, Grant. That was a little while ago. He seemed to like the blue cupcake. So my daughter, she just gotten this new princess castle, and I don't know if it wasn't the one she wanted or what the deal was there, but she was showing her disapproval of something. I'm not sure. You know, unfortunately, one of the reasons that we get together and we do multidisciplinary care and we work so hard is because, you know, cancer eventually brings a lot of deaths, unfortunately. What we've seen is since 1930 up until about the year 2000, that was at a steady linear increase. Then in around 2000 we started to see that level off, which is which has happened for a number of reasons, and of them is because we have physician scientists and researchers. We have new targeted therapies like Dr. Gupta talked about, those small molecules, those arrows, those bullets that target cancer cells and really focus in on those abnormal cells in the body and are able to kill those cells. We also have new surgical techniques. We have these robots in the operating rooms that do all these magnificent things, and we have researchers that are continuing to work day in and day out to form new and more advanced treatments so that hopefully we can change that plateau into a decline over the next several years. We haven't reached the summit yet. We hope to get there. We hope to start changing the trend so we can see those numbers start to decrease and decrease rapidly. But we have a daunting task. There's still 600,000 people almost on a yearly basis that are succumbing to cancer. It's only surpassed by heart disease in the U.S. So we have quite a challenge ahead of us. It's an uphill battle, but it's a battle that we're all fighting every day. There's new innovation and there's new things occurring all the time that are helping us start to beat that fight. Some of the obstacles that are in front of us are that a lot of cancers are found in the late stage. Unfortunately, no one is there to tell us, hey, you got some abnormal cells growing and you need to get to the doctor. And a lot of times we may think we have the flu, or we have a lot of different excuses as to why we're feeling bad, and we don't really think, oh, maybe I have cancer, maybe something inside of me is growing abnormally and it needs to be treated. So not only do we not really understand or know, but we're getting to doctors later and they're coming to diagnoses later, and unfortunately at that stage it's oftentimes much more difficult to treat. Okay, so the first thing is going to be surveillance. That's one of the areas that we're doing a lot of work on, and is finding these cancers earlier. One of the other limitations is that when we do present late, it limits our ability to do surgery. We do know in the medical field that surgery is usually going to be kind of the definitive therapy. If you can get in and you can cut the tumor out and you can remove it, that takes it away. You've kind of beaten the battle, or at least started in the process of getting ahead of the game. You get all those cancer cells out, all right? Some of these new chemotherapies, even though they're beating cancer in many ways, they have side effects. They can't always be given at the optimal doses, and so when not given at optimal doses, they often become a little bit less effective. That's one of the other obstacles that we have to face in this fight against cancer. Radiation suffers from the same things. You know, sometimes we're using chemo, sometimes we're using radiation. But radiation in and of itself is going to have some of this, devastation to the normal cells that are surrounding the cancer cells. This collateral damage that Dr. Gupta talked about. And so, there are still limitations that we're trying to overcome. Obstacles that we're overcoming include new resistance of tumors. Tumors find ways to work around all of our new chemotherapies. So that's one of the other obstacles that we're fighting in this challenge against cancer. I was fortunate enough to find a nice picture of Dr. Gupta, so I thought I'd include it on the talk today. Traditional paradigm in cancer care includes a whole group of physicians: medical oncology, radiation oncology, and surgical oncology. All of these folks working together, providing their own, special niche, okay, to treat different types of cancer. Here at St. Vincent, we try to take it to the next level. We look at every case as an individual case. We go over and we discuss the cases in a multidisciplinary fashion at our tumor boards, where each of the doctors from those different specialties get together and they add their little bit of insight into how they think this cancer should be treated. We make individualized treatment plans for each patient so that they can have a comprehensive care and they have the ability to get all different types of treatments for those specific cancers. One of the new pieces in that cancer puzzle that we've been working with over the last 5 to 10 years is this concept of interventional radiology or interventional oncology. It's something that has really only been around for about the last 10 years. And some of the treatments, which I'm going to talk about here, are really, kind of this cutting edge or new treatments that are going to be used in combination with those old treatments. So we're doing it in conjunction with chemotherapy or along with radiation therapy, along with surgery, acting as adjuncts to those other therapies. So here are some of our interventional oncology solutions to those problems that I pointed out, or those obstacles that I pointed out earlier. Late-stage presentation or late-stage diagnosis. Fortunately, in interventional radiology, we have the opportunity to use some of those arrows in our quiver to potentially downstage the disease, okay, to make tumors smaller so that they can potentially get surgery or make them more sensitive to chemotherapy. Patients are oftentimes not able to have surgery because of their other conditions, whether it's heart disease or lung disease, severe diabetes, something that limits their ability to have surgery. Interventional oncology, our techniques are minimally invasive. All right, patients come in on that day, they leave that same day. We don't have the same restrictions as far as comorbid diseases such as heart disease and lung disease. So we're able to treat a wider group, or cast a broader net in this population, and able to treat more patients that way. Our treatments are often more focused in some respect. We're using an artery or we're using a small needle to get to the tumor, all right? And in doing so, we're having less collateral damage, so there's less systemic side effects that occur from our treatments, which are more focused. And working together with Dr. Gupta and the oncologists, and working together with our surgeons at St. Vincent, our treatments often become synergistic. And so those tumor cells which have become more resistant to therapy, over the years, we're now able to potentiate each other's treatments and really start to treat these tumors at the next level. Some of the options that we have for treatment, and forgive me, these are just what they're called. I know, so radio frequency ablation, microwave, it is what it is. But the basis are percutaneous ablation. Okay, that's when we introduce some device into a tumor and apply either hot or cold to kill the tumor. It's as simple as that. There's chemoembolization. That's when we use a chemotherapy agent that Dr. Gupta uses. That we kind of connect it to a small particle and we administer it into an artery to treat the tumor. And then there's radioembolization. Same concept. We're using small particles which are administered into an artery to focus in on tumor cells that are living in the liver. We're not a replacement to surgery, but fortunately, When you come to me and you don't see a surgeon, you don't have to deal with this. Ablation technology, as I kind of touched on a minute ago, is simply heating or cooling a tumor until it dies. Okay? Normal cells and tumor cells, once heated to about 108 degrees, will stop functioning normally. Once they get to about 115 degrees, that's when cell death will start to occur. So don't move to Phoenix because everyone there is going to die, right? No. Fortunately, our body stays at a homeostasis and keeps our body, cellular level much cooler than that. But when we introduce these thermal devices into the tissue, we're able to heat them at greater than 115 degrees Fahrenheit and then able to subsequently cause those tumor cells to die. Here's what it looks like. When we do ablation, patients are usually in like a CT scanner. If you've had a diagnosis of cancer, you've had a CT, you've been in a CT scanner. It allows us to localize the tumor. Once we have localized the tumor, we use our device, then guided with the CT, to insert into the tumor. Once we see it into the tumor, the machine turns on. The tumors are then heated. They heat for about 10 to 15 minutes. After that, the electrodes are then removed. No stitches, no prolonged recoveries. Patients are back up and out of the hospital most of the time the following day. But who can get ablation? Ablation, from my perspective and from the literature out there, is the closest thing we have to surgical resection. When we ablate a tumor to complete necrosis, we can get nearly the same survival, or not quite, but as close as we can to actually surgically removing and getting those cells completely out of the body. But unfortunately, not everyone's a candidate. Who's a candidate? Patients that have focal tumors. So if you have a couple of tumors, up to maybe even 4 tumors that are focal, that can be well seen by imaging and that can be accessed percutaneously. These are the patients that can have this type of treatment. If you look at this CT scan here, you'll see that there's, all these spots are tumors. Okay. You couldn't really put a needle into those and burn each and every one. You'd kind of create a Swiss cheese. So, ablation isn't right for everyone. There is a population of patients that we can use this type of therapy for, and we can reach nearly surgical levels of survival. In patients like this, though, don't fear, because we still have treatments for those, and that's when we go to an arterial approach. We'll go into the arteries and we'll administer one of those things I spoke of, the chemoembolization or the radioembolization, to then treat those tumors. This is how we access. You can see there's a very small incision, a small sheath that's entered into the femoral artery. A catheter is then guided up into the liver, and then we start to isolate all the arteries in the liver, trying to find which ones are supplying blood flow to the tumor, as we have shown here. We get catheters out into those arteries that are supplying blood flow to the tumor, and that's where we're going to be then administering our therapeutic devices. And why can we do this? So, the liver is an interesting and an amazing organ, and one of the unique things about the liver is it has a dual blood supply. Most organs, your kidney or your spleen, they have a single artery that goes to that organ and it supplies blood flow to the organ, which supplies its nutrients. The liver, on the other hand, actually has 2 blood supplies. There's an artery, which is the big red guy, and then there's the portal vein. That's this blue guy that's coming in here. The portal vein, in a normal situation, provides about 80% of the blood flow to the liver. So it's providing 80% of the nutrients and requirements for the liver to survive. The artery, on the other hand, will only supply about 20% of that blood flow. When tumors start to grow in the liver, they start producing that VEGF that Dr. Gupta talked about. That angiogenesis starts to occur. And the angiogenesis, those signaling factors, what they do is they start to get arterioles to form. They don't really cause portal veins to start growing. Their signals are found only in the arteries, so it then kind of causes the arteries to form blood flow to the tumors. What that allows us to do is to more focus our treatments. When we deliver it into the hepatic artery, we have less of a fear of affecting the whole liver than we do if you try to do something into the portal vein. The portal vein still allows a safety net to perfuse the majority of the liver, allowing us to get higher doses of chemotherapy and radiation into the tumors. First thing is chemoembolization. You can see here's one of our catheters that are deep out into the liver. First thing we do is we take a look at what the blood flow looks like. We find the vascular flow to a tumor, all right? Chemotherapy, we use these small beads, and they've been soaked in one of the chemotherapy agents for several hours. During that soaking time, a bond is formed between the chemical agent and the sphere. These spheres are about 100 to 500 microns. This is just a solution here. It's kind of an aqueous solution, and you can see it's like a sediment at the bottom. The individual spheres can't really be seen. They're small enough to where you wouldn't really see it, but you can see the sediment of millions of those spheres at the bottom of the aqueous solution. They've been soaked in the chemotherapy for several hours. The bond that's formed between that bead and the chemotherapy is one that will last days to weeks. So then once implanted into the tumor, that chemotherapy is slowly released over the course of days to weeks, and that's when it affects the tumor. It goes into the tumor cells and works its own function in killing those tumors. What's our goal? Our goal is obvious: survival and decreasing the amount of tumor that there is, and increasing survival while maintaining quality of life. That's one of the biggest things that I look at when treating patients is how can we maintain the best quality of life during that time. And the great thing about these kind of therapies is that you really don't have a whole lot of downtime afterwards. The patients are able to recover quickly. There are side effects, don't get me wrong. The more times people are treated, the more those side effects build up. The more kind of chemotherapy you're on, the more those side effects build up. In general, though, these therapies are very well tolerated. Our hope is that we can downstage to surgery. That's my goal in a lot of patients, is trying to focus in the different types of therapies we have to downstage those tumors, to at which point they can then be removed. And then, oftentimes our chemotherapy and our radiation therapies are able to optimize surgery. We're able to get it to a state where, the surgery is more successful, and that there's more or fewer treatment complications from that surgery. Y90 or radioembolization, it's one of the kind of the focuses of today, and it's a really unique treatment. I like it in particular because when compared with the chemoembolization, it's shown to be a lot more tolerable. Patients have fewer side effects. When I do a chemoembolization on a patient, I kind of prep them beforehand. You're going to be in a lot of pain for the next couple of days. You're going to stay overnight at the hospital. And there are significant side effects from this. When we use the radioembolization, in general, it's not across the board. There are fewer side effects. Patients tolerate it a little better. This radiation, yttrium is a particle that emits a high energy radiation from it. And it's implanted into the tumors. Here are the spheres. These spheres are actually even smaller than the chemoembolization spheres. This is the size of a human hair. These spheres are 20 to 40 microns in size. They emit high energy radiation. And the great thing is this radiation, once it's implanted into the tumor cells, the distance which it travels is millimeters. okay? So you don't get beta radiation outside of you. It's safe for the people around you. You only get it within that 2 to 4, up to 10 millimeter area right around the tumor, right around where those spheres are implanting. That's the area that is affected by the radiation. All the other, everything else around you is preserved. There is an interaction from the radiation with your normal cells that emits some X-ray. Okay, so if you're a companion of someone who had the treatment and you're sleeping in bed with them for the next couple of days, you're going to get a chest X-ray basically. So we give you've had a couple X-rays, right? But in general, it's safe. It's safe for the people that are around you. Most of my patients will go back to work, and the people that at their work are not at risk of having high doses of radiation. It's safe for the public. It really is only affecting locally around the tumor and in the tissue that it's embedded on. And who can get Y90? So this is the group of patients that aren't going to get ablation, that aren't going to get that RFA therapy. Patients that have multiple tumors in both lobes of the liver. These are the patients that we can get our catheters into.
I think most people don't realize how tiny.
Yeah, so I'll pass this around. This is actually a vial of the spheres. This is not radioactive, right, guys? No, I'm just kidding. What cancers are we treating? Well, it's FDA approved for colon cancer that has metastasis to the liver. But here at St. Vincent, we're treating a lot more than just that. We're treating patients with breast cancer. We're treating patients with neuroendocrine tumor. We're treating patients I've treated patients that have ovarian cancer that's spread to the liver, cervical cancer that's spread to the liver. Excuse me, gastric, yeah.
When you treat patients who have breast cancer or any of these things, who pays for it?
Okay, so yeah, no, that's a good question. So we go through a process. The process first starts off with coming to see me in clinic or one of my partners in clinic, okay? We go over your history, we go over your imaging. We talk about the procedure, explain it to you, explain to you what's going to happen next, okay? Then I write a letter of medical necessity. We get that off along with a packet that includes your history and why you need the therapy. That packet, then we work with the company that makes the spheres, and we send that off to the insurance company, and we do what's called a predetermination process. That process can take anywhere from a couple of days to a couple of weeks. Oftentimes when it's not colon cancer, what happens is the insurance company says, you know, we're not going to pay for this, or we need to talk to you personally. And so what happens next is I'll write another letter, I'll call the medical director at the insurance company, and I'll jump through a few hoops and I'll talk to a few people, and usually in the end we come up with a positive predetermination. And what that means is you're not going to get the treatment until we've assured with your insurance company that they're going to pay for it. We don't get you in and then send this big bill. We go through a bunch of steps. I talk to a bunch of insurance companies on the phone on a weekly basis to make sure that things are getting paid for. Also, we treat patients with renal tumors that have spread to the liver. The reality is any solid organ tumor that spreads to the liver, all right, and has blood supply from the hepatic arteries can be treated with this therapy. The idea is that it has to be deriving its blood flow from the hepatic arteries or from the arteries around there. It has to be something that I can get to with a catheter, and then we can treat it, okay? It has to be in the right setting, though. I mean, not every patient is going to be a candidate for it, but in most settings, we can look at imaging and we can get the patient treated. The liver is still, at this point, a unique organ. because of that dual blood supply that I talked about a little while ago, and we can treat more safely in the liver. It's not really being done in many other organs yet at this point. It would still be research to do it anywhere else, and it'd be hard pressed to find an insurance company that would pay for that. But in the liver, if there are tumor in the liver, almost from any other primary, we can treat it. So how do we get through this whole process? And I kind of just touched on that when I answered your question. Is the first thing that happens is patients are discussed in these multidisciplinary conferences. Treatment plans are made between surgical oncology and medical oncology and myself. Then you get referred. There's a clinic visit. In that clinic visit, I try to take as much time and answer as many questions as I can, go over the procedure with you, talk to you about the side effects, and really kind of work you through the whole process. After that interventional oncology visit, there may be continuing workup, there may be more imaging that's needed, but then the whole process occurs in a stepwise fashion. The first thing that's done is you come into the hospital and we do what's called a mapping procedure. That is to make sure that it's going to be safe for us to administer the radiation. We want to get the radiation into the liver tumors. We don't want to get it anywhere else. And the blood supply in and around the liver can often be somewhat complex and difficult. And so we need to make sure before we go in with these radioactive spheres that we're going to be able to safely administer the spheres into the tumors without affecting other organs, without causing radiation pneumonitis, or without causing stomach ulcers, or some of these other things that can happen if radiation gets outside of the liver. After we do that safety or mapping procedure, you're scheduled for an implantation, which occurs a week or two later after the mapping procedure. Patients come into the hospital that morning. Typically will leave that evening or the next morning. Most of the time they'll leave that very same evening. Within a day or two, usually we try to have one of the staff in our department give you a call and see how you're feeling. If you're having side effects from the therapy, then either you come back and see us or you go to the local hospital to find out exactly what's going on and make sure everything's okay, and then get treated from there. After that first treatment, in most cases, we're dealing with 2 treatments, and so anywhere from 2 to 6 weeks after that first treatment, depending on the type of tumor you have, depending on the extent of tumor, depending on your clinical status, how healthy you are and how able you are to tolerate the treatments, and depending on what type of chemotherapy you're on, will determine how long after the first treatment until the second treatment. Like I said, sometimes it can be between 2 weeks up to about 6 weeks after the first treatment, the second one will happen. After that point in time, you just kind of go back into the same follow-up process. It's all a process, as we know. We're taking it step by step. We image, we find out what's going on, and we devise a new plan. And that's kind of how we work through that whole process. What happens next? I think at St. Vincent we kind of have a very nice process. We have a unique situation. We have patient navigators, we have schedulers, we have team leaders. We have lots of ancillary staff that are here to answer all your questions, that are there when I'm not available, to help guide you through the process, to help answer questions and get you to the right place when needed. We have a whole vast array of nurses, medical assistants, physicians assistants. Everyone's available. Someone's available all the time to answer your questions and move you through the process and help you if you need something. And by utilizing all these different people, we hope to continue to bring hope, and we hope to start to overcome some of these obstacles in the treatment of cancer. Any questions?